Hello, my name is Marissa Reidemeister. I'm going to be talking about case number 3 and case number 4 in the Unit 4 Case Connections assignment. So I'm going to start off by reading a little bit of the case number 3. A 47-year-old man presents with severe pain in his right great toe. He is unable to bear weight on his right foot and there was no apparent trauma. He reports the pain started last night and continued to increase in severity. Based on his physical exam and laboratory findings, he is diagnosed with gout. And then a couple of his lab results are listed, and then the question is, what is the best explanation for the presentation of gout in this individual, and please explain why the other choices are not consistent with the data, or what additional information you may need to decide the root cause. 1 is overproduction of purines, 2 is decreased salvage of purines, and 3 is decreased urinary excretion of uric acid. After further discussion with the patient, he tells you that he recently switched from diet soda to regular soda. And what is the potential impact of this dietary modification on the presentation of gout? So for my response, the purine synthesis pathway involves several steps to synthesize the double ring structure of adenine and guanine. Because they are difficult to break down, a specialized salvage pathway occurs. In purine synthesis, we activate a 5-carbon sugar to the active sugar form, PRPP, using the enzyme PRPP synthetase. Next, additional carbons and nitrogens are donated from folate and amino acids to form a secondary ring structure. The final closed ring structure is called IMP, which can produce AMP and GMP. AMP and GMP can then go through a series of reactions that will transform them into adenosine and guanosine, eventually leading to the production of uric acid. Gout can be caused by overproduction of purines, decreased salvage of purines, and underexcretion of uric acid in the urine. The presentation of gout for this patient can be explained by an overproduction of purines. Purines can be produced in the body and consumed in the food we eat. This patient reports an increase in his intake of fructose, which has been shown to increase purine metabolism. This causes an increase in the uric acid, which has negatively impacted this patient's joints. High levels of purines can produce uric acid crystals, which accumulate in tissues and joints. If the body cannot process the purines at an equal rate as they are present, uric acid builds up in the bloodstream. This diagnosis can be supported by the symptoms reported by the patient in addition to the lab work conducted. A decrease in purine salvage pathway activity is often diagnosed as Lesch-9 syndrome. This condition is characterized by a deficiency in the enzyme HGPRT. This deficiency inhibits the purine salvage pathway by inhibiting the conversion of guanine and hypoxanthine back to their nucleotide monophosphate form. This leads to an increase in urinary uric acid levels. Based on the lab results, this patient's urinary uric acid levels are lower than the normal levels, which means they are likely not experiencing decreased purine salvage. In addition to the inflammatory joint response, this condition is often clinically presented by neurological symptoms and impaired renal function. This patient is not experiencing either of these symptoms, so this is not a likely explanation for the patient's gout. I also do not believe the patient's gout is caused by a decreased urinary excretion of uric acid. The patient's urinary uric acid result is lower than the normal range for this test, which might indicate some level of decreased excretion. However, this usually occurs when one consumes a significant amount of alcohol. Since the patient hasn't reported increased alcohol consumption, I would do a BAC test just to see if there's any alcohol in the blood to rule out any recent alcohol consumption that might lead us closer to an answer. So that is my response for case 3. And then for case 4, the question is, a 58-year-old woman presents to the emergency department with progressive fatigue and weakness for the past 6 months. She is short of breath after walking several blocks. On the review of systems, she mentions mild diarrhea. She has noted intermittent numbness and tingling of her lower extremities and loss of balance while walking. She denies other neurological or cardiac symptoms and has no history of black or bloody stools or other blood loss. On physical examination, she is tachycardic to 110 beats per minute. Other vital signs are within normal limits. Her head and neck examination is notable for pale conjunctivas and a beefy red tongue with loss of papillae. Cardiac examination shows rapid regular rhythm with a grade 2/6 systolic murmur at the left sternal border. Neurologic examination reveals decreased sensation to light touch and vibration in the lower extremities. No depression noted. And then the question is, which of the following vitamin deficiencies is the probable cause of this presentation? Discuss how this vitamin deficiency impairs purine or pyrimidine metabolism, and list potential laboratory tests and findings that would assist in your differential. And my response is, the patient is diagnosed with megaloblastic anemia, which is a type of anemia characterized by abnormally large, immature red blood cells produced by the bone marrow. Patients with this condition may be asymptomatic for years, but can slowly start to develop symptoms which include fatigue, shortness of breath, irregular heartbeat, gastrointestinal symptoms, and a red tongue, amongst other symptoms. Megaloblastic anemia is caused by a deficiency of vitamin B12, also known as cobalamin. A deficiency of this nature can result from poor vitamin intake in the diet, poor absorption by the intestine, or inadequate use of the vitamins by the body. Since cobalamin is found in foods such as meat, fish, and eggs, a poor dietary intake is possible but rare. This is mostly seen in vegans. Poor absorption of cobalamin can occur due to an IBD condition such as Crohn's or colitis, in which the intestinal lining has a difficult time absorbing essential vitamins and minerals due to the ulcerated colon. This patient is not suffering from iron deficiency anemia, so iron deficiency is not likely the cause of her symptoms. This patient is also not displaying symptoms of a vitamin B6 deficiency, which include a red rash, prickling sensation in the extremities, seizures, and cracking corners of the mouth. Vitamin B12 plays an important role in the DNA synthesis by providing structure within regions of the chromosomes and assists with the production of purines and pyrimidines. This patient is displaying symptoms of megaloblastic anemia. As a physician, I would order a CBC panel of blood work to check the appearance of the red blood cells. In patients with megaloblastic anemia, the red blood cells appear larger and immature or underdeveloped. I would also conduct a physical exam to rule out any other possible reasons for the patient's symptoms. Additionally, I would do a Schilling test, which is a blood test that evaluates the person's ability to absorb vitamin B12. In this test, 2 urine samples are given for analysis. One of them is given after consuming a radioactive supplement of vitamin B12, as well as a protein needed by your body in order to absorb the vitamin. The 2 urine samples are then compared to see if your body is able to produce the intrinsic factor protein on its own, or to see if it fails to do so. Megaloblastic anemia can be managed with injections of vitamin B12. On the other hand, some people have a mutation in the MTHFR gene, which is responsible for V vitamins. People with this mutation might require supplemental methylcobalamin. And that is my response. Thank you.